Greetings and welcome to our presentation on increasing funding opportunities by using research domain criteria. I'm Mehl-Madrona and I'm representing my colleagues Dr. Josie Conti, Patrick McFarland, and Barbara Mangi. And we're recording from the Eastern Maine Medical Center in Bangor, Maine, where I work with the Family Medicine Residency. And also, we're affiliated with the Medical Arts and Humanities program at the University of Maine and the Coyote Institute. So, first I want to explain what is research domain criteria. So, the National Institutes of Mental Health are rejecting the DSM, Diagnostic and Statistical Manual of the American Psychiatric Association, and the International Classification of Diseases as a way of diagnosing and partialing symptoms for research. And why is that? It's because DSM and ICD are not based in neuroscience. They're the result of consensus opinion and are diagnoses that are arrived at in a kind of botanical method of classification in which we check boxes. So we have a list of symptoms, and if they fit the diagnosis, you get the diagnosis. And the problem with that is that you can get multiple diagnoses, that DSM and ICD diagnoses can be overlapping, contradictory, and vague. And this can hinder adequate research. So NIMH has decided that diagnoses are needed that are based in brain function and circuitry rather than expert consensus. And so applications for funding to NIMH need to rely upon neuroscience-based categories rather than DSM or ICD. And I know to many behavioral health faculty and researchers, it's quite a new idea to criticize DSM. It's been with us for so long. But it began in a hotel room in Baltimore, and it's continued to be consensus-based rather than neuroscience-based. So research domain criteria are based on three ideas. The first is that psychiatric disorders are brain disorders with a primary focus on neural circuitry and neural networks. So they're primarily disorders of connectivity or of the capacity to leave one network and activate another. So this is in distinction to neurological disorders that have identifiable structural lesions. We'll talk more about brain circuits in a moment, but brain circuits include the reward or seeking circuit, the fear or extinction circuit, executive function circuit, impulse control disinhibition circuit, story brain or default mode network, to name a few. And of course, contemporary neuroscience is looking at functional circuitry as more important than what we used to think about, which is the question of what does a particular part of the brain do. So now we know that circuits can put together various brain areas to perform functions, and that a brain area can be in more than one circuit, so that the circuit, when activated, recruits that brain area to perform a function for it, and then when deactivated, it leaves that brain area free to be activated by another circuit. So, so research domain criteria classifications also assume that the tools of clinical neuroscience, such as electrophysiology, functional neuroimaging, and biochemical markers, can eventually identify dysfunctions in neural circuits. And we're certainly seeing that now with PET scanning and fMRI. So, so the idea is that data from genetics and clinical neuroscience will ultimately yield bioprints, which will help us to more effectively differentiate clinical signs and symptoms. And if you look in the lower right, you'll see a Danish troll, which is not hard to diagnose once you've seen one. So, the other problem with DSM is that it ignores the neurodevelopmental aspect of psychiatric disorders. And so, all psychiatric disorders are simultaneously neurodevelopmental disorders because development influences the brain. So, maturation of neurons interacts with external influences beginning at conception. Risk factors include prenatal infections, early childhood abuse and neglect, and trauma. So, DSM and ICD do not provide integrative developmental models that differentially lead to resilience or to psychiatric disorders. They don't provide an understanding of why a particular insult may lead to a particular disorder. For example, early life stress being a risk factor for major depression, post-traumatic stress disorder, or borderline personality disorder. So, research domain criteria asks, what is the normal distribution for a certain trait or a characteristic? And what is the brain system that implements this function? So, in that regard, RDC would say that there are no pathological traits, that traits are considered pathological at the extremes of their distribution. So, so everyone is a little manic, can be a little manic, but it's at the extreme of the distribution that people are diagnosed. But everyone has those traits that compose mania. Similarly with depression, which we could consider to be many different syndromes depending on how we unpack it. But in the classic melancholic depression, all of us can have some of those characteristics on particular days, but just not fall into the extreme. So we want to understand what accounts for the dysregulation or dysfunction in these systems alongside these normal to abnormal dimensions. So, this is in distinction from the standard approach, which defines a mental disorder by signs and symptoms and then seeks a diagnosis. So, so just to review the shortcomings of DSM, that there is extensive comorbidity among diagnoses. And I'm sure that all of you have seen this. You've seen people with 4, 5, 6, even 8 diagnoses, which makes no sense at all considering that they only have one brain. That there's an overspecification of categories, that there is a massive overuse of the not otherwise specified diagnoses, and that the current categories do not represent contemporary knowledge about genetics, neural circuits, and neurotransmitters and behavior. So, we want to try and get away from the infectious disease approach to mental disorders. So, we don't want to sort people by the presence or absence of disease. We want to look at traits and characteristics and their distribution and look at the substantial number of people whose number or severity of symptoms places them in between diagnostic categories or in subclinical spheres that are often ignored. So we're anticipating a continuum approach. And this means that some degree of psychotic phenomena are present in the normal population and in broad ranges of psychiatric outpatients. So, consistent with this view, symptoms are dimensionally arrayed in a population and not simply a manifestation of qualitatively distinct severe pathology. So, bottom line, we're all a little crazy. It's just a matter of degrees. So, now, when we teach residents to family medicine residents, primary care residents, to prescribe from a research domain criteria, then what are some of the foundational ideas? And one of the things that consistently appears in the meta-analyses, and my favorite meta-analyst is Adriana Cipriano from Oxford University. It turns out in her work, drugs within any particular class are generally equivalently effective for the target symptom for which they're being used. What differs are their side effect profiles. So we're teaching our residents to prescribe based on side effect profiles from particular classes of medication, and not to imagine that one is any better than any other. And another foundational idea is the recognition that just because something is FDA approved for a particular indication or not FDA approved doesn't mean that it's not useful or that it is useful. FDA approval is a lengthy, expensive process, and pharmaceutical companies tend to undertake it only for one indication, assuming that clinicians will figure out the other uses for the drug and will just naturally adopt it for those uses. So this means that what drugs are called doesn't necessarily describe what they do. So what they're called is for marketing, and what they do is often quite different. So so-called antidepressants appear to work better for anxiety than they do for depression. Antipsychotics are useful for depression, for anxiety, for obsessive compulsive symptoms, for a host of conditions. So the DSM diagnosis doesn't necessarily help us choose a medication or understand the patient's experience, their lived experience, but they're necessary for billing. So for prescribing, we want to think about circuitry. What are the dysfunctional circuits for this patient, and what are the neurotransmitters that mediate those circuits, and how could we perhaps increase the activity or decrease the activity of those circuits using medications. So some further foundational ideas are that we treat symptoms and not diagnoses. So when we prescribe, we target a symptom and we monitor and measure that symptom, and not asking the question, did we cure the diagnosis? And sadly, today, psychiatric prescribing is largely trial and error, and there is a large placebo and probably some degree of nocebo responding also. We know that the placebo response rate for antidepressants ranges from 48 to 60%. So that's huge. And medications add anywhere from 0 to 12% to the placebo response. So, so this lends itself to a great deal of trial and error. And it's hard to know what will be helpful for any given patient. And just to mention the recent popularization of genetic testing, what it tells you is how rapidly the patient metabolizes or fails to metabolize a medication. It doesn't tell you what will work. And in my practice, I've only found it useful when I'm at the top of the dosing range and I've had a partial response, and I want to know if the patient is a rapid metabolizer so that I can justify raising the dose above the manufacturer's suggested maximal dose. So, so let's think a bit about drug categories now to go along with these circuits. So there are medications which modify the pre and postsynaptic serotonin receptors. So these would include the SSRIs, the tricyclic antidepressants, the SNRIs, some of the atypical antipsychotic medications also work on serotonin receptors. So quite a few. There's drugs that modify norepinephrine receptors, which include the tricyclic antidepressants, the SNRIs, and of course beta and alpha adrenergic blocking agents. There's amphetamines and stimulants, which include some tricyclic antidepressants like dizipramine, stimulants like modafinil, and of course methylphenidate, Adderall, those kinds of medications. There's dopamine agonists like bupropion and the tricyclics. There's dopamine blocking agents like the first and second generation antipsychotics. There's agents that act directly on GABA receptors like the benzodiazepines. There's voltage-gated sodium channel blockers, which are the anticonvulsants. There's medications that enhance the function of GABA, gamma aminobutyric acid, which are some of the anticonvulsants. There's drugs which reduce the release of glutamine, which include some anticonvulsants and some calcium channel blockers. There's peroxisome proliferator activated receptors agents, which include some anticonvulsants. There's medications that reduce the levels of pro-inflammatory cytokines, which include the SSRIs and the NSAIDs. So, time for a quote from Rumi, who said, "Study me as much as you like. You will not know me, for I differ in 100 ways from what you see me to be. Put yourself behind my eyes, and see me as I see myself, for I have chosen to dwell in a place you cannot see." And for me, this gets to the heart of the need to explore people's lived experience of their emotional suffering. That when I ask people about depression, if I ask 100 people who say they're depressed what they mean by that, I'll get at least 10 different categories of collections of symptoms. Sometimes people mean that they're angry when they say they're depressed. Sometimes they mean that they're so worried that they're overwhelmed. Sometimes they mean they're lacking in all motivation and in a state of melancholic collapse. So we have to unpack the terms that people use to understand their experience, to know what brain circuits are involved in what's going on with them. And the DSM diagnosis does not necessarily help us to do that. So this brings us to the question of what are the symptom categories that correspond to brain circuits. So we have symptoms that fall into the class of loss of seeking or diminution of the value of reward. So we get loss of interest, abulia, indifference, sort of collapse into melancholia, excess sadness. Second, we have the category of excessive worry, so hypervigilance, ruminative thoughts. Third, decreased attention, fatigue, scattered focus, distractibility. Fourth, excessive seeking behavior, and that can include what people call racing thoughts, hyperactive behavior, quick shifts of attention. Fifth, we see failure to error detect, that people don't notice that they're behaving inappropriately and don't recognize the cues that they're getting from other people or from the environment. Sixth, we have decreased executive function, decreased capacity to take care of business. 7, we have excessive fear, freezing, sense of constant danger, panic. 8, we have excess attribution of external agency. And closely related to that is the excess drawing of correlation where coincidence will suffice for the explanation, and we call that paranoia. 9 is dysnarrativia, which is the inability to tell a good story. 10, we have disorders of salience. How important is something? 11 is disorders of sleep. 12, disorders of emotional regulation. So what are some of the brain circuits that correspond to these symptoms? Well, we have the sadness circuit. We have the seeking system or the reward system. We have the attention and orienting system. We have story brain, which is also called default mode network, because when our brain is on default, we make up stories about the important people in our lives, which is why it's also called social brain. We have the error detection circuitry, executive function circuitry, fear circuitry, paranoia circuitry, storytelling circuitry, salience circuitry, sleep circuitry, emotional regulation circuitry, impulse control circuitry. So all of these matter, and contemporary neuroscience is about figuring out what circuits are involved in particular behaviors, characteristics, and traits, and this is primarily being done with fMRI. So, just a couple words about the seeking system, which some people call the reward system. And it's what gets flooded with methamphetamine and cocaine and floods your system with dopamine. And once you've experienced that, normal life seems like a drag. So we've got the mesocortical dopamine system and the mesolimbic system. Mesolimbic relates to motor behavior. Mesocortical relates to what it is we're looking for. What are we trying to find? And dopamine is what mediates that system. It's what do we want? What are we looking for? Jim Olds was the person who called this the reward pleasure reinforcement system, though others have argued that it, Panksepp in particular, that it's more likely to be that we get more pleasure from seeking than finding. So I'm getting to the end of my time. I'm happy to talk to people about this and to continue this conversation, which is an ongoing conversation about how to translate neuroscience into clinical practice. And I invite you to email me at louis.mehl-madrona, no hyphen, at maine.edu to continue the conversation. So I thank you for listening.